Hey everybody, welcome back to the ECG of the day. My name is Reed. Don't forget to download the PDF that is linked in the description below and like and subscribe to this video if you enjoy this content. So let's jump onto the EKG. So first thing I like to do is look at the forest, and the trees of my forest are the QRSs, and so I might just pick a lead here, maybe V5 at the bottom, and I see I've got a regular rhythm here. It appears to be somewhat narrow, and my rate, if I pick a QRS that's right on a solid line, which I would say maybe this one's pretty close, I get 300, 150, 100, 75, just a little bit less than 75. We'll call that 70 beats per minute, so it's a normal rate. And as I scan across here, I see that there are no skip beats. It's pretty regular. I notice that there are P waves here in front of every QRS. That's somewhat reassuring. So let's go ahead and go down our pathway to approach this ECG. So first thing we're going to do is evaluate the atrial activity, and we do that by looking at our P waves. I notice that there are P waves before every QRS, and I also notice that I've got a P wave that is upright in lead 1, but if you notice, it is down in AVF. So that means that my P wave axis is going to the left, and it's going up. So it's going up and to the left, which is not common for a sinus P wave. So I would call this P wave ectopic P wave. So this is, I would not say this is sinus rhythm. I would say this is an ectopic atrial rhythm, right? Because our sinus node, which is located here in the high right of the right atrium, usually when it depolarizes, it's going to go down to the left. But we're seeing something that is going up and to the left, right, based on our P wave morphology. So we've got an ectopic P wave. We notice here that the ectopic P wave is present throughout the entire strip. So if I come down here again to lead 2, I notice that every P wave is the same morphology, right? And you can march that all the way through. So we're going to verify that this is the rhythm that's driving the ECG. So that's our atrial activity. Let's talk about the next thing in the conduction system, which is going to be our intervals. I like to look at the PR interval first because that's the AV node. PR interval here, if I pick maybe this QRS here, my PR interval is normal. My PR is less than 200 milliseconds, so that is normal. So our AV node, we can say, is working well. Next thing we look at is going to be our QRS. Our QRS we said is narrow, and we can come and measure that. We say our QRS, if we look here, QRS is less than, so the QRS is less than 120 milliseconds. My axis of my QRS is upright in lead 1, but it's also down in AVF, so that means it's going up and to the left. So I've got somewhat of a left axis deviation here. So left axis deviation, right? It's going up and to the left if you look at our heart. So maybe some left axis. Okay. What can cause left axis? Well, we know like maybe bundle branch blocks can cause left axis deviation, but this is a narrow QRS, so this isn't a bundle branch block. Maybe hypertrophy could, left ventricular hypertrophy, but I don't see any evidence of that when I look at my lateral leads here. I don't really see any large forces. So okay, and we'll kind of maybe understand why this is happening here in a little bit. Next thing we're going to do is look at our QT intervals. I like to do that by sometimes just eyeballing it. I'll look in between two QRS complexes. So I'll pick this one, I'll pick this one. If I measure right in the middle, my T wave should be done by then, and I would say that that is the case generally. So my QT interval is good. All right. So next thing we're going to do is we're going to look for pathological Q waves. And so when we scan through our pathological Q waves, at the same time we'll look for ST and T wave changes. What I notice here is in my inferior leads, which are leads 2, 3, and AVF. Leads 2, 3, and AVF, I'll do this in green. I'll zoom in on them here. So my inferior leads, 2, 3, and AVF, they have these deep Q waves, right? The first deflection is a deep negative deflection. My first deflection is deep and negative in all of these inferior leads. So what that tells me is that there are forces that are going away from those leads, or in other words, these leads are unable to conduct signal in that direction. And so that tells me these pathological cues, that is highly specific for a previous infarction, myocardial infarction in that region. Previous could be any time. It could be 10 years ago. It could be 10 minutes ago, right? So it doesn't necessarily tell us the time, but it tells us that it has happened before and this myocardium is not viable. So we've got pathological Q waves here in the inferior leads. There are leads 2, 3, and AVF, right? Those are inferior leads. What you also notice is there might even be just a little tad hint of ST elevation here, just maybe a tad, and we've definitely got, with those, we've got these T wave inversions as well. The ST and T waves don't look great in these leads, and what you don't know about this patient is they just had a cardiac cath for an inferior STEMI. So this patient had a STEMI within the last 6 hours. They got a cath to relieve the obstruction, and so now you're seeing the aftermath of somebody who has a myocardial infarction with some of their infarction that damaged enough of the myocardium so that it couldn't conduct in that direction. And so this person just had that occur. So kind of fun little clinical correlation there. And so let's put this all together now, because we've gone through our algorithm. So this is a ectopic rhythm at a rate of 70 beats per minute with a previous MI noted with pathological Q waves in the inferior leads of 2, 3, and AVF. And so as you think before, why did we have this left axis shift? Well, it's probably because if you look at our heart here, we had a lot of myocardium, I'll put it in red, in the inferior leads that was damaged. And so electrical activity only has really one option, and it's to polarize away from that region. So when you think about axis shifts, we think a lot about bundle branch blocks, fascicular blocks, but in this case, this axis shift was caused by an inferior myocardial infarction. So I hope this helps. If you like the content, don't forget to like and subscribe to the page, help support our videos. I love putting out daily videos, and throw your questions down into the comments, and have a great day.